Welcome, Alberto Espay, to the Exploring Health Medicine podcast.
Thank you, David. I appreciate the invitation.
You'd like to introduce yourself to the listeners?
Yeah, I'm a neurologist who has subspecialized in movement disorders. That means I see patients with neurological disorders that affect movement, either too much movement, excessive movement in conditions such as Huntington's disease, or deficit of movements in conditions such as Parkinson's disease. But in the process, I've been interested in neurodegenerative diseases, and that means I end up trying to think about what is it that brings out conditions that accelerate neurological aging. And so I have extended my area of interest to Alzheimer's and other neurodegenerative dementias.
Yeah.
I have a busy clinic and research practice at the University of Cincinnati. I've been here for about 20 years now.
Yeah. And you have this Cincinnati Cohort Biomarker Program as well there, right?
That's correct. Yeah, that's the first effort that is meant to act as if we mean it when we say no two patients are alike. We've been saying that for a while, but never quite done the type of effort that's needed to ensure that we are indeed looking at each individual for what he or she has. We've been trying to continue our effort of finding markers of diseases as we've defined them, but in that process, we are losing the trees for the forest. We're not quite able to explain to an individual why he or she has the condition we're declaring at the bedside.
So, if I understand you correctly, you're looking to get a more individualized, a more specific to the individual comprehension and method for explanation for the particular patient.
Exactly. And that's a method that we borrowed from oncology. Cancer experts would say to someone, you have cancer in your lungs, for instance, or in your breast or in your prostate. And that is not to say that's a disease. That is, they cover the book, but we don't know what disease it is. And oncologists would further that by saying we need to do a variety of different tests to try to determine why this happened, and then to know how we're going to treat your condition. We don't do that. We come up with a diagnosis that's clinically based, meaning that we do a neurological investigation, examination at the bedside, and then based on that, we determine if that person has one diagnosis or another. And when we declare that diagnosis, we assume that's the final answer, when in fact this or should be thought of as a placeholder diagnosis.
How do you mean placeholder diagnosis?
Well, a diagnosis is a tentative. It's like saying breast cancer. That's a placeholder diagnosis. Breast cancer is not a disease. Breast cancer is many different diseases. And one saying breast cancer immediately recognizes what does that mean to an individual. Well, that's what is required to be done to understand what actual disease we're talking about when we say breast cancer for Mary. And that disease for Mary might be very different to Julia's breast cancer and to other individuals with the same diagnosis, a placeholder diagnosis, but not necessarily the same disease explaining that diagnosis.
I see. So there are different biomechanistic, pathogenetic explanations for the different patients' underlying conditions, but they're both called Alzheimer's or Parkinson's.
Exactly, you got it. That's the case. Unfortunately, culturally, we still are at the developmental stage in which when we say Parkinson's, we mean a disease, and we shouldn't. when we say Alzheimer's, we mean a disease, and we shouldn't. I'm not suggesting that we need to change the name and start numbering the different kinds of Alzheimer's, but I'm simply saying that when we say Alzheimer's or Parkinson's or frontotemporal dementia or dementia with Lewy bodies or any of these conditions, we should hasten to add to a patient, we don't know what disease that actually is in you. And CCBP, the Cincinnati Cohort Biomarker Program we have here in Cincinnati, is a way to answer to that challenge. We have to be able to, at some point, answer the most important question: why this happened to me? We tell patients what we think of what they have and give them a name for the disease we think they have. But the most important question to resolve is, why did that happen? And that has to be individualized. We used to say, well, the condition you have is likely the confluence of genetic susceptibilities and environmental exposures that have come together to create the conditions for this condition that you have, Parkinson's disease, for instance. In reality, that is logical, but it doesn't say much of anything that is actionable at the individual level. So it's a lot of heavy work to get into the business of trying to identify the individualized biology, but we have no option, or we shouldn't have any other option. It's the only way to get to a point where we can eventually deploy the principles of what's referred to as precision medicine, is to recognize that we won't have a cure of Parkinson's, because Parkinson's is a very heterogeneous collection of diseases, nor of Alzheimer's, nor of any other condition, but rather we will cure different types of Parkinson's, different individuals with different kinds of Parkinson's, one at a time, after we recognize what is it that they have and match them to therapies that act on the specific biological change that we can recognize is at play in each of them individually. And so what's going to, again, cure Mary's Parkinson's, for instance, will not be what's going to do so for Jim or George. They have things that are in common, but that which is common across them is not what matters from the perspective of what caused their individual brand of disease.
Yes, I see. Before we go into the CCBP study and the particular biomarkers, as I understand, it's many of them that are going to be included in this study. I want to talk a bit about the, well, for Alzheimer's disease, there's this popular theory or hypothesis of amyloid being a central protein, which when it's misfolded or when it's present in purportedly toxic forms, it can contribute to the pathogenesis of Alzheimer's disease. And now I know that the treatments that are currently studied, and some have been approved by the FDA, for example, Lecanemab, and they're quite controversial. And I have gotten the understanding while reading some of your work that you are not convinced by the amyloid hypothesis. Can you explain why you're not convinced of the amyloid hypothesis? And also, do you think we can do work on the amyloid hypothesis, keeping lecanemab and similar therapies, the development of them going, and at the same time going down this precision medicine route? Or do we have to focus all the resources on one of the paths?
Well, that's a hard overall question, but let me start by saying that hypotheses are not to be believed or not believed. Hypotheses are scientific ideas that should be falsifiable, meaning that there is an experiment whose outcomes you can trust, if negative, to falsify the hypothesis. And what has happened with the field of neurology is that we have become enamored of our hypotheses. We love them. We have tremendous faith in them. We believe in them. And belief is not or should not be in the language of science. So it doesn't matter whether I believe in the hypothesis or I'm skeptical of the hypothesis. What matters is what is the evidence for and against the hypothesis. The evidence for the hypothesis only comes from animal studies that have shown that if you give animals aggregated proteins, especially in forms of pathology we refer to as amyloid plaques, or if we give them as Lewy pathology, whatever, animals get sick, and if you remove that from them, they get better. So you could argue that is an argument in favor of the hypothesis. In humans, however, that hypothesis has never been confirmed. And we use the word hypothesis without really meaning it is a hypothesis. We might as well call it the amyloid principle or the amyloid law. That's how we treat it. We don't treat it as a hypothesis because no matter how much evidence there has been against it in humans, we always manage a way to keep it. And when you keep a hypothesis past its expiration date, you end up with treatments such as Lecanemab that give us the illusion that it is finally a validation of that which we all along believed to be true, when in fact it isn't. So why is it not the validation of the hypothesis that we have Lecanemab approved by the FDA? Because despite the marked reduction of amyloid, in fact, in some cases with elimination of any amyloid in the brain, people continue to decline. And we can explain the same cognitive changes that happen with amyloid reduction therapies using monoclonal antibodies, such as lecanemab, by the increases in A-beta-42, which is the protein from which amyloid plaques come. And it turns out that A-beta-42 was invisible when we first came to understand what Alzheimer's was. We saw these clumps of proteins in a crime scene, that's called the autopsy, which in a crime scene that would have been the corpses, the villain, not the villain, but the victims. And yet we framed them villains. We framed them as perpetrators of the crime. So we failed to interpret a crime scene according to what forensics experts would say. You're seeing corpses. That is probably the consequence or the victims of something else. We need to figure out how the crime got committed. We skip all of that and we assume that amyloid plaques, tau tangles, neurofibrillary tangles, Lewy bodies, etc., all of these corpses that we came to refer to as pathology were somehow the causes of the problem. That generated the hypothesis. The amyloid hypothesis meant to say that amyloid plaques are the cause of Alzheimer's disease. Lewy pathology is the cause of Parkinson's. Tau accumulations are the cause of progressive supranuclear palsy, and so forth. And that causality is not true. It's not that Alzheimer's is caused by plaques, but rather it's caused by a variety of different biological mechanisms the brain reacts against by transitioning their A-beta-42 proteins into plaques, in the process losing A-beta-42, and the plaques become the marker of that reactive mechanism the brain has undertaken. So we've been chasing a tail. And it is very clear that when you look at both ends of any protein story, in the case of amyloid plaques, the other end is A-beta-42. These are at a population level an inverse relationship. The more the plaques you see, the less of the A-beta-42 there are. But it turns out that most of us with amyloid plaques are normal. Why? We have identified the reason for it, which is that rather than having an inverse relationship, those the individuals that manage to have lots of plaques but are normal, which is most of us within a normal lifespan, is because we keep up levels of A beta 42 above a compensation threshold. And that is actually much more meaningful as an explanation of why we are, quote, resilient. There's a line of research speaking of how is it that we can be resilient despite plaques. It's not despite plaques. Plaques are not toxic in any way. It's because we need to look at the whole thing, and the whole thing tells us that we have plenty of plaques as a result of our brain reacting is a variety of biological, toxic, infectious exposures, which of course increase as we age in prevalence. We can do that if we manage to continue producing enough of the normal protein. So that's why it's not that I'm skeptical of the amyloid hypothesis, it's that I know that the amyloid hypothesis is false, and we have just not been able to articulate it because there are many forces against it, not least of which are collective belief. And again, going back to the idea that belief isn't or shouldn't be in the language of science, we believe in it. And when you have belief, that is a formidable wall against evidence. It doesn't matter what experiments are going to disprove it, we believe. And it is very unfortunate because at the end of that belief is a variety of different experiments and trials, and overall just a body of research that has continued to not question, but find ways to validating and confirming and demonstrating that we are right, as opposed to questioning whether the idea isn't false. There's a book called How Not to Study a Disease, which I recommend to read cover to cover. It's written by a neuroscientist under the name of Carl Herb from the University of Pittsburgh. And he goes through each of the different milestones in the history of Alzheimer's research, showing the many holes of any of the ideas that we came to embrace as part of Alzheimer's. And yet, not even him, with all of this evidence to show that the amyloid hypothesis doesn't hold up much weight, doesn't go and end the book with saying, well, it's time to move away from it. He comes up with a few ideas of what we need to do in terms of research that are somehow complementary to the amyloid hypothesis, but he doesn't go as far as saying the amyloid hypothesis must die. It's very unfortunate. So anyhow, we're doomed to have a lecanemab, this monoclonal antibody approved by the FDA, and donanemab just the same. But they don't do what they claim to do. The only thing that's good about these drugs is that they do increase A beta 42, and that's data that's sort of almost under the rag, so to speak, because it's published in supplementary materials. You would think that would be a very important element of the reporting of the monoclonal antibodies. That really never was published in the main manuscripts, such as the New England Journal of Medicine article published in the Lecanemab trial, but rather you have to go into the supplementary materials to know that the A beta 42 levels in the case of lecanemab go up quite a bit. So that's good, but everything else is bad because removing amyloid from the brain is very toxic, can give rise to swelling and bleeding that we have sanitized under the term ARIA, amyloid-related imaging abnormalities. It just sounds perfectly fine when you say ARIA, but that is swelling of the brain and bleeding in some cases. So that's not trivial for the brain at all. It also shrinks the brain. And overall, you have to apply statistical methods to find that there is a difference from placebo. It's not as if patients can identify a benefit. There is no such thing. So quite unfortunate. And then ultimately, these drugs caused an acceleration of brain atrophy. And in any alternative universe, a smaller brain would be a cause of concern.
Yeah, and they are very expensive as well.
Exactly.
The treatments. And I spoke a few weeks ago with Dag Selin, who is a researcher who played a role in the development of Lecanemab. It was developed to a large extent here in Uppsala, actually, where I'm based. And well, from his perspective, the clinical effects of having a 27% reduced progression of, rates of progression of the cognitive decline was a key finding in
Let me
why.
let me stop you right there, because if you say a drug slows any disease by 27%, oh my goodness, of course we need to use it. That is the manipulation of data. That is a relative risk reduction. It's a relative risk reduction. Is not what matters to patients. Patients matters the absolute risk reduction. It's relative to the placebo arm in that study. Is not what patients experience. Patients do not experience a 27% reduction in the decline. It's a beautiful number to manipulate, but what matters to patients is what kind of change can they perceive, and this drug is leading to a change that's imperceptible. Is half of what's the minimal clinical important difference. So the 27% sounds amazing, except that it is a relative risk. It's not an absolute risk. It's kind of like the statins. When you think about the statins, people think, well, it's about 25 to 3% reduction in the events of strokes or heart attacks, right? Oh, then everybody should be on it. That's the relative risk. The absolute risk reduction is about 0.5 to 1%. So I think that depending on what number we choose to interpret the data, it could seem either very good or absolutely trivial. And of course, the company has chosen to maximize the 27%. But if that was a 27% change, we would see it, and statistics would not be needed. we would see it. So it is false. By the way, I have to parenthetically say, companies have been brilliant at manipulating the information and sanitizing it in such a way that even an expert podcaster, as you are, or scientists that have managed these concepts, they use those terms. 27% is amazing. I mean, it's quite remarkable. In fact, donanemab is 33%. But that's even more remarkable. It's the same level as it relates to, it doesn't donanemab. But when you look at that one number, oh my gosh, it is remarkable. By the way, people die from this as well. ARIA, the swelling and the bleeding, it's not that people recover completely from it. It may well be, as it's been shown by one study done in Australia, that this is the main risk for from the brain atrophy acceleration. So I think that's very important. And when you compare the data of lecanemab to the data of donepezil using the same cognitive endpoint, donepezil emerges as twice as effective. And donepezil is an old drug now. We think of it as modest, but if you compare the two data sets, donepezil emerges as better. And that is almost a 3-year-old drug. It says a lot about the field of Alzheimer's research and the blind allegiance to the amyloid hypothesis, that 3 decades after the last drug ever approved by the FDA for mild Alzheimer's, declared to be modest but significant, is now finally, by virtue of a new approval, being looked upon with different eyes. Wow, in retrospect, that drug was amazing. Remarkable that the latest approval of the FDA is so trivial in terms of the change that you need to use statistics and relative risk reduction with 27% to then go back and look at the donepezil data and realize donepezil was amazing in retrospect. And
Yeah.
we should be giving donepezil. And by the way, just one last comment. So there have been 51 trials of anti-amyloid treatments before we got these approvals. 51. That right there tells you that we don't take no for an answer, because the trials were either futile or actually negative in the sense that the drug was worse than placebo. Believe it or not, of the 51 trials, 20 showed that placebo was superior statistically than the interventions. And it's only 4 of all those trials that show the opposite, show the arm, the anti-amyloid monoclonal antibody was better statistically than placebo. So 5 times as many studies have shown placebo better over the intervention than the other way around. We have chosen the losing horse if this was a gambling sport, a horse race. We really are it's quite remarkable. We should be giving people placebo rather than this, which is safer and can be effective.
Yeah. I mean, I see myself as a future researcher. I read quite a bit of research, but still I find it very difficult because there are people who seem like on the surface they know what they're talking about, like the researcher I spoke with a few weeks ago, and you also seem to know what you're talking about. It's hard for me to know, like, because you're saying completely opposite things are true, and it's hard for me to know, and I'm guessing it's probably even harder for a patient to know for sure. How do you suggest a patient weighs evidence, interprets like the quality of the sources as regards who to trust and how to reason at their level of understanding?
It's fascinating. The point you're making is that with the same body of data, we can make different stories, and it's true. I'm going to tell you one of the most poignant examples of that is a study that was done where individuals, mid-age individuals, were asked to undergo a PET scan that captures amyloid plaques. In all of the ones that were recruited for this study had a negative PET scan. They had no amyloid that was detectable by PET. They were asked to sleep deprive themselves one night, to try not to sleep only one night. And the very next day, they underwent another PET scan, and lo and behold, it was positive. So the individuals that sleep deprived themselves within a night changed from PET negative to PET positive. Had no amyloid to begin with, and then had amyloid quantifiable at the next day. Conclusion of the study: sleep deprivation is a risk for Alzheimer's. Okay, sure. It fits into the narrative that people with Alzheimer's have quite a bit of sleep problems in many cases, and we all know that if we don't sleep for 2 months, we're going to be demented anyhow, right? So it's certainly one possibility, and that was how this particular study was interpreted. But with the same body of data, you can say that sleep deprivation represents a sort of injury the brain reacts against by forming amyloid. It's the same body of data, completely different interpretation. It all depends on whether or not you are including any biases into the data. And if you think amyloid is toxic and you now have amyloid, then you have to say that, well, this is the beginning of your Alzheimer's. And it is not the case. Amyloid can't be toxic because amyloid is the cross beta configuration of a protein. So essentially, if I have a, of course, it's very hard to illustrate this, but let's say that I have a piece of tissue. I know that this is only meaningful if you do a video, but I will describe. You have a piece of tissue that's really quite malleable. That represents a state of solubility, and proteins must be soluble to undertake their functions, to adopt their three-dimensional configurations that allow them to carry out whatever the proteins are supposed to do. When they are reacting against something, they adopt a pack configuration, which is a cross-beta pleated sheet. And cross-beta pleated sheets are the most stable configurations in nature. It's like a little stone, if you wish. It is just very, very compact. It's so compact that it is impossible for it to be toxic. This is why in all autopsy studies, there is never a relationship of how much of the plaques you have or any other pathology, again, cross-beta configuration, and degeneration, or how much of these plaques you have and how worse your clinical symptoms are. No correlation whatsoever, because it's doing nothing to the brain. It's a marker, not a maker. It's not creating some kind of a toxin that the brain now has to fight against. Not at all. It's simply an evidence the brain is reacting normally to something the brain shouldn't have to deal with. And those kinds of things continue to increase in prevalence as we age. And that's why within a normal lifespan, a simple majority of the population is going to have amyloid plaques and tau tangles. It is because our brains are normally reacting to these exposures, but only a fraction of us will have dementia. It should be that if 60% of the population by the age of 85 has amyloid and tau in their brains, then 60% of the population should have dementia. And that's not the case. So most of us with amyloid plaques will never go on to develop dementia as if amyloid were toxic, which it isn't. And that's so important because much of the efforts that are done now to continue using monoclonal antibodies in research are predicated on the idea that the earlier the better. And the earlier is always better if you know what you're doing. But we say the earlier is better because look at the results we get with Lecanemab. Oh, it's puny. If we had given that much earlier, it would have been better. Not true. Not true at all. In fact, there have been 4 trials of monoclonal antibodies already in what's referred to as preclinical Alzheimer's. Preclinical Alzheimer's is defined as having amyloid and be normal. We could have preclinical Alzheimer's without us knowing if somebody does a PET scan of our brains and finds amyloid. Now we have preclinical Alzheimer's. There have been 4 trials, and all 4 have shown that those on placebo continue to be normal. Those on the anti-amyloid therapy develop cognitive impairment. So we already have the data to know that this is just a normal reaction of a normal brain as we age with a variety of different things we need to fend off against. Not a toxin, because if it were a toxin, the preclinical state would have been the perfect state to demonstrate that. So we already have all the evidence we need to conclude that amyloid isn't toxic and that the amyloid hypothesis is false. And the fact that we cannot say it in a manner that's public enough is why we're where we are. And patients suffer because now patients get the illusion of progress with Lecanemab. They think that's better than nothing. And it turns out it's worse than nothing. In this case, nothing, I think, is better. In fact, I know nothing is better than Lecanemab for many reasons. Plus the financial toxicity it inflicts in families and the healthcare system. because this is incredibly expensive. Someone like me, my own conflict of interest as a doctor is that it behooves me to prescribe lecanemab. I don't get paid based on how the prescriptions I issue, but my hospital system does get paid more the more prescription I do. And so technically I should be prescribing this widely if my motivation were the bottom line, which it isn't. But so there are all sorts of difficulties with this. But the most important is that it is only these new therapies are only providing us with an illusion of progress, not real progress. And patients are the ones that suffer because they are very much desperate with good reason, and anything that seems progress, they just take it.
Yeah, I think you're making some strong arguments here. I want to move on to the biomarkers and the Cincinnati Biomarker Cohort Program, or the Cohort Biomarker Program, right?
The Cincinnati Cohort Biomarker Program. Yeah, no, let me tell you, because you had mentioned, and this is now the time to say, you'd say, well, is the biomarker program going to be in conflict with the therapies that will look at the other side of protein homeostasis? And so the reason we're doing CCBP, the Cincinnati Cohort Biomarker Program, is because we want to identify why each individual has a disease. But one thing we know about people with Alzheimer's is that they have low levels of the beta-42 across that, regardless of why it is that they have Alzheimer's. It's universal that they have low levels of the beta-42. People with Parkinson's, they have low levels of alpha-synuclein in CSF. It doesn't matter what kind of reason it is that they ended up having Parkinson's with. So what we're proposing is that one element of disease modification can be rescue therapy, increasing the levels of the proteins. If A beta-42 can be increased to normal levels, maybe it doesn't even matter why is it that an individual developed Alzheimer's, because we have a rescue approach. Precision medicine is not that it's mutually exclusive. Precision medicine can run in parallel, and that's what CCBP is about. It's trying to identify why an individual is having a compromise of their own proteins such that they're depleting their A beta-42 or their synuclein or their tau, whichever proteins we may be interested in examining. And then going after the source, trying to treat that at the very source. So these two are programs that are running in parallel. One that is aimed at understanding what kind of strategies we can use to increase the levels of proteins, and that's rescue. And the other one is trying to target people for the specific mechanism that is driving their disease, and that's called precision medicine. Precision medicine requires splitting. Rescue therapy doesn't. We can continue to lump in the case of rescue therapy endeavors. But for anything else that relates to disease modification, splitting is needed because that's the only way to truly have successes in delivering precision medicine. So I hope that's clear in terms of why we're doing our cohort and why it's not in conflict with the idea of turning the tables around with regards to protein. We don't speak of proteinopathy, disease of the proteins, but we speak of proteinopenia, the loss of proteins, because that's really what is more tightly connected to how people's diseases are in terms of their severity.
Yeah, I do think that clarifies. How many people are going to be involved in the study, and what biomarkers are going to be measured? Because when I read about this, there were fecal samples, there were urine samples, blood samples, cognitive assessments, including online assessments. Can you describe like how many different markers, for example, for urine, and how does it work when how does the selection process for which markers that are going to be taken for a particular individual, how does that process work?
Yeah, great question, David. That is one aspect that's very different between what we do and what has been done. So the markers around that perhaps most of us know about are biomarkers of convergence, means that they have been developed across a population. Let's say neurofilament light, NFL. That's a biomarker is widely used now. It's a marker of axonal degeneration, so it goes up when neurons are getting damaged to a point where they're disappearing. We're not interested in those kinds of biomarkers because they are just terminal biomarkers. They're convergent biomarkers. We're interested in divergent biomarkers now. The kinds of things that we are most interested in deploying as biomarkers are bioassays. Bioassays that are developed on the basis of neuroprotective interventions that already exist, because one goal of getting to know the biological subtypes of disease is so that then we can understand how to treat people. That's the only reason we're interested in this, is to find a way to treat them. Many of our patients today might have treatments for their disease, not for their symptoms, for their actual disease, if we knew why they had the problem, if we knew what the underlying biology driving their disease is. So we are in the process of developing these assays for 5 neuroprotective interventions that have been already tested and, of course, failed in trials, with the idea that if we knew that if we have a range of the assay and a particular treatment is from which the assay was developed, meant to increase the levels of something, then that assay that is probing what the levels are for that particular component of biology, we're looking for people who are 2 standard deviations below the mean to then select them for then a subsequent N of 1 trial with this particular intervention. So as you can imagine, it's not exactly what different markers we're measuring, but rather what assays we have that connect to therapies that already exist from the biology perspective and are going to be able to select patients on the basis of their biology for those therapies for future trials. So that's sort of the key aspect. Now, that is not to say that we're not interested in a more unbiased biomarker development process. And by that, we mean that in part using artificial intelligence, we would be able to start in a phenotype agnostic fashion, determine the different omics signals that are of interest. Proteomics, metabolomics, and other omics are technologies that or ways to measure aspects of biology in an unbiased fashion. But the only problem is that so far, all the omic studies have been based on a particular cohort. The independent variable is the clinical diagnosis. Phenotype agnostic means the independent variable now becomes the signals of interest, and the dependent variable is what diagnosis we give, and also how deeply phenotype patients' characteristics may be between one subgroup and another. So that's the other analysis. But again, that analysis is designed to ultimately identify the small but biologically homogeneous subsets of individuals for whom a particular line of therapy may be effective as a disease modification. So those are the 2 approaches. So then what you say is we measure, as you were pointing out at the beginning, we measure blood, urine, microbiome, plasma, PBMCs. We don't do CSF unless patients are undergoing lumbar puncture for other reasons. In that case, we then collect our CSF. But as you can see, that is the most important piece of data, because we also do cognitive assessment, motor assessment, but that's not just so that we can separate people into tremor versus no tremor, or dementia versus no dementia. That's not what we're trying to do this, because that's what all the other biomarker programs have done, right? They use a clinical or phenotypic characterization as the basis on which then all the analyses are done. And we're not interested in that, because we know we're going to find things that are different between people with dementia versus without dementia. But that definition, dementia, is man-made. We're looking for things that are not man-made, for things that actually are going to separate individuals into their biological subtypes. So biological subtype is what we're interested. Do we think that once we have different biological subtypes of interest, because of the therapeutic relevance, that somehow they are going to track into a specific clinical phenotypes? Probably not. I bet that even in the future, once we are able to identify these subtypes of therapeutic relevance, we might still find that they are clinically heterogeneous. So I don't envision a time where we can say, now that we've identified X or Y subtype of Alzheimer's or subtype of Parkinson's or whatever, if we have these specific clinical features, we can predict what the biology might be. I don't think we'll ever get to that point. Maybe exceptionally we might, but by and large, I think that's not attainable. But it's very similar to the field of cancer. You cannot imagine an oncologist saying that based on the palpation of the right upper quadrant of the left breast, the texture and the nodularity predicts that will be a particular molecular biological subtype of breast. No, that's just, I think that we have to recognize, as much as we love our semiology, our characterization of the phenomenology of movement, that we will not be able to ever translate that to a specific molecular biology. So I hope that's giving you a flavor of what we're doing in terms of the program and what our goals are. It's been a hard program to put together and to continue and sustain, because a lot continues to be invested at a societal level in what we've done forever. It's actually more comfortable to continue doing the same thing we've always done, but this is required. We just don't have much of a choice in this regard. We just have to keep at it, and our goal is to have our first success in precision medicine before this decade is over.
Yeah, I'm looking forward to seeing the results. And
Thanks.
yeah, and so if I understand correctly, the samples from the fecal microbiome, the urine, the blood, and the CSF of the participants who were going to do the lumbar puncture anyways, and they are then analyzed through, like, with an assay of different biomarkers, or like what biomarkers are analyzed. Can you?
Well, that's what I'm saying. So we don't have the names of many of the ones that we're interested in yet, and those are, to me, defined because just like when you do omic studies, you don't go in and say, well, I predict that X, Y, and Z markers are going to be. So we don't have the name. So we know what we're doing and how we're doing it. We don't know what we're going to find. In many ways, this is one of the aspects that create the anxiety in all of us, because we like it is in a manner of speak, a fishing expedition where it's an exploratory study, and it's always much more comfortable to say, this is what we think we're going to get. These are the compounds that we think these are the markers that we think are, and we wish we can be at that level because it's more comfortable, but it's unfortunately quite uncomfortable to know that we don't know what we're going to get. We don't know where the markers that are relevant to Mary's Alzheimer's are going to be found, or where those 4 genes will be found either.
Yeah, makes sense. Did I understand you correctly that you're going to be actually looking for outliers as regards the normal distribution of results in this case? Because normally you even exclude outliers in many research contexts, right? But in this case, you're actually looking for the outliers.
We're looking for the outliers. The outliers are the ultimate way of splitting because they are telling us something meaningful about a particular element of biology, and those are individuals that might, depending on to which side of the tail end of the bell curve we're talking about, we are going to be able to tease those out and then identify them as potential candidates for a repurposing trial of a drug that will have them no longer be outliers from a biological perspective, right? So bring them over to normal in that regard. Now, the challenge with this, of course, also is that there are going to be signals that we think are relevant and may not be. The case in point for that came from the SURE-PD3. This SURE-PD3 trial was a trial that increased the levels of uric acid through inosine in patients who have low uric. It's the only study in Parkinson's that has pre-selected individuals on the basis of a marker, low uric acids, because of the inverse relationship with progression. Low uric acids are associated with a faster progression, and so the idea was to bring the uric acid to a high level without creating gout or kidney stones, and then that's the level where the progression will be slow. Well, that was achieved from a biomarker perspective using inosine, and nothing happened to individuals. So that's an example of us chasing a tail, even though it looked like the relationship between uric and progression was very clear. It must have been something else the uric acid was telling us about, not necessarily the uric acid was a proxy for something else, maybe many different things. And this is just a common denominator of that. Low uric acid is a feature of about 40% of people with Parkinson. So it turns out that probably just too large a slice of the pie to have been meaningful. And that's why sometimes we need to do the splitting has to be even with thinner slices, so to speak, to be able to get to our first success in precision medicine. But I'm bringing this as an example or a cautionary tale that not necessarily every signal that we think is important may be meaningful to correct. We might be improving a laboratory abnormality, but not necessarily the individuals. And so that's something else that is also haunting us to some extent in terms of what is it that we might end up getting.
Yeah, I see. So there will have to be follow-up confirmatory studies once this exploratory study has been completed and the results are in.
Exactly.
Yeah. And if listeners take away just one message from this conversation, what would you like it to be?
I want all of us to be skeptical about every bit of information that comes to us. There is a lot of research done to support models, to confirm ideas, to validate, but very few to actually question the concepts. And so I think the key aspect is that advances only come when ideas are rethought, revisited, and replaced with better ideas. And if you have a field where an idea has been dominating excessively, like the field of Alzheimer's, you end up with things that are not going to be good to patients. So, my key message is that our patients depend on us not to try to prove that we are right, but to ensure that we're always searching for the truth, because that's what's going to make the greatest difference for them.
Yeah, and I appreciate that you are playing your role in that search for the truth. And
Thank you.
you've written, yeah, you've written a book about, among other things, what we talked about today. Do you want to tell us about it?
Sure. I wrote a book called Brain Fables, and it is an exploration of the different milestones of knowledge across Parkinson's and Alzheimer's, and it as a way to get to those milestones, uncover the data that gave us the ideas that we now take for truth, and then realize that different interpretation emerges from each of those milestones. So it's a way to revisit the story of Alzheimer's and Parkinson's from the data that created those stories, but looking at the data without the biases, just letting the data speak for itself, as opposed to attributing to that data meaning that we have wanted the data to tell us. So it's a way to learn about how we came to think the way we do, and why we have to consider alternative ideas in both Alzheimer's and Parkinson's.
Yes. And I'll make sure to link to somewhere where listeners can listen, both listen to, because it's available as an audiobook, I know, and also read if they prefer that. I'll provide links in the show notes. Yeah.
Wonderful.
All right. Thank you, Alberto, for coming on the Exploring After Medicine podcast.
Absolutely. My pleasure. Take care.